This original WSRE presentation is made possible by viewers like you. Thank you.
Hi, I'm Dee Dee Sharp, and welcome to part 2 of the Aware Healthcare Forum. And as you know, in part 1, if you were able to join us, we highlighted and defined terms such as health insurance exchanges, individual mandates, and pre-existing conditions. And we even got a chance to compare the similarities and differences of the Affordable Care Act and the new health care plan, the American Health Care Act of 2017. We also examined how the new tax plan may impact your health insurance coverage. Now, on part 2 of our program, we'll focus on navigating the new law. We'll also let you know how you can find local and national resources to help you make the best health insurance decision for you and your family. And of course, our panel of experts are here to take audience questions and guide us on through this maze. Once again, we want to introduce our panel of experts. From New York University's Langone Medical Center and host of co-hosts of the HealthCare Connect, which airs on Sirius XM's Doctor Radio program, we have Andrew Rubin, Vice President for Clinical Affairs and Ambulatory Care. We also have Allison Vogel, Vice President of Managed Care. And last but certainly not least, we have Matthew Penziner, who is the Executive Director of NYU's Physician Network and Clinically Integrated Networks. Once again, thank you all for being here on The Aware Show. We're glad to have you here with us. It's so good to have you back. As we mentioned in the first half of our program, we had you all here about 6 years ago. And again, we're talking about healthcare reform, and all the different things that are going on now under the Trump administration. Want to get to some of our audience members who may have questions for you all here this evening. So if anyone does have a question and they want to ask, please step up to the podium, and we'll get to you in just a moment. Coming back to us right here on the stage, let's talk just a little bit about kind of rehashing where we were last half a part of our show and where we are now, just to bring our viewers who may be just joining us up to speed. Start with you, Matt and/or Andrew. Allison, who wants to take over? Where we are, how we got to where we are with healthcare reform and the American Health Care Act of 2017.
So the where we are now in the country is essentially where we were last year, with a few changes, a few actually significant changes that may or may not ultimately impact what's happening on the insurance exchanges in the coming years. We have the health insurance exchanges. A lot of people still ask us on the show, are the health exchanges still operating, or are they still running? The answer is yes. Okay. Open enrollment is now closed. In previous years, in the Obama administration, the opportunity for people to enroll in health care insurance went beyond the beginning of the new year. Under this administration, the enrollment window was shortened to 6 weeks, but it was still open. We have more expensive insurance on the exchanges. Healthcare insurance plans have gotten more expensive. People are paying more than they paid last year. People are frustrated by that. And in many parts of the country, we have places where there are no options available at all. So you go on the exchange and there are no plans available. So we are in 2018 in an environment where we still have healthcare reform as the law of the land. Obamacare still exists, but it is in a very weak state. And what happens in the next year or two? Will health insurance premiums continue to rise? Most likely they will. Will Congress finally start working together and fix some of the problems with the current law that we have? And we certainly hope they do, for everybody's sake, all your viewers and studio audience participants' sake. We hope that people come together and work together. The only big change for this year, as I started to say, is the individual mandate is gone. That was part of the law that required people to buy health insurance. That no longer exists. If you didn't carry health insurance in the past and you met the criteria, you would pay a penalty. And that penalty is now gone. And we'll see what the impact is in the coming years. Allison and I, as we talked about in the first hour, are not, I'm hopeful and optimistic based on our callers, our listeners, who tell us they still want to have health insurance, that people buy health insurance because they know inherently that it's good for them, and that the mandate, while important, I guess, on some level, people didn't buy the health insurance because they didn't want to pay a penalty. I'm hoping that that's the case, that people bought health insurance because they wanted health insurance. Allison's not as optimistic as I am, but we're going to see in the next year or two what happens.
I think that it's one of the things that unfortunately will further destabilize the health insurance marketplace. I mean, like we discussed earlier, that the way health insurance companies price their premiums, you need to have the healthy people in the pool, so you have the money in there to pay for the sicker people. So without having those healthy people in there, the insurance companies are going to be a little bit cautious of how they're going to price their premiums in the future. So once again, I think that's going to be another way of destabilizing, and that may be a factor of why insurance premiums are going to continue to rise significantly in the future. So
it's so amazing to me, Dee Dee. And we talked about this on our show so often. The American public never really got behind Obamacare, healthcare reform, the Affordable Care Act. And despite the fact that 15, 20 million Americans signed up for health insurance that didn't have it in the past, in general, the public never, liberal, conservative, didn't matter. A lot of people just never got behind it. Whether they didn't get behind it because they didn't understand it, it wasn't sold properly. President Obama, who I believe, did not use the power he had as an orator to sell the plan properly. Whatever it was, people were against it. And what we saw in the fall of last year, when we were talking about getting rid of it, the public instantly changed tune, and the plan that was being put forth by House Speaker Ryan to eliminate health care reform was wildly unpopular. And fortunately, it didn't pass, but it was wildly unpopular. I'll never fully understand the American public when it comes to that. They were against it, and they had good reasons to think it wasn't working well. Higher premiums, less choices than they thought they were going to get, or they were told they were going to get. But then when we were telling them that it may go away, the very thing they didn't like, they instantly embraced it and said, no, don't get rid of it. We may not like it, but don't get rid of it.
That's the American way. We don't like to get rid of anything once we get it.
Exactly.
Even though we don't understand it.
It was really fascinating to watch.
Very good.
And see happen.
We have a question at the podium. We're going to go right there.
Yes, good evening. Thank you so much for coming down from New York. Healthcare is a very important issue for me. I'm retired Navy, disabled veteran, and I have Tricare, and of course I have the option of using the VA. But I was notified last November that I'm eligible for Medicare, so I'm using the healthcare systems that they have out in the economy here, Sacred Hearts Baptist Hospital. And I heard someone mention that, like you said, within 6 months of obtaining the Medicare services. I just wanted to know if that's age-related, because I didn't sign up for anything else. They were saying for the Medicare Advantage or anything like that, because I thought I had pretty much everything that I needed. And usually with Tricare, when I go, they take the Medicare and the Tricare, and there's usually no copay. So, and I'm 58, so, and I've had Medicare for over, since last November. So I was wondering if there's something additional that I need to apply.
You have Tricare for life, right?
I have Tricare for life.
You don't need a supplement. So Tricare for life is the secondary insurance to Medicare. So if you have Medicare, you don't need Tricare. You don't need a secondary policy. You have the best insurance of anybody probably in this room. You also don't need a Part D prescription drug plan, because all your prescription drugs are covered under the Tricare for Life program. So you are in very good shape. One of the misconceptions 6-7 years ago was, would there be a change in military benefits as it relates to healthcare, the Tricare program, and would there be a change in Medicare benefits? And the answer to both those questions back then was no, and today is no. You will hear in the coming months, now that tax reform is complete, there'll be a lot of conversation about changes to entitlement programs And that's a code word in Washington for Medicare reform and Medicaid reform. We saw it last week with Medicaid demonstration projects being approved, where they're going to require, states will require, they'll submit an application to allow them to require beneficiaries to have to work in some way, shape, or form to get Medicaid benefits. When they're going to talk about reducing the cost of the Medicare program, they're not going to eliminate benefits, but they're going to eliminate payments to hospitals and doctors, or make it harder for doctors and hospitals to get paid. So you'll hear a lot about changes to the system in the next year, but you won't lose your benefits. And you happen to have some of the best insurance available, and as a disabled veteran, you are most certainly entitled to them. And thank you for...
Thank you so much for sharing that information.
Yeah, thanks for the question.
And thank you for your service.
Yeah. Yes,
we didn't get your
absolutely.
name. I want to recognize you.
I'm Mildred Smith, retired petty officer Mildred Smith.
All right, you go, girl. Thank you so much for being here on The Aware Show. Next.
Good evening.
Give us your name, please.
I'm Mrs. Betty B. Wynn Ellis, and I'm going to try to keep this as brief as possible. Also, not a military person per se, but I'm a military ex-wife of an officer. So I don't get everything she gets, but I do get the retirement part. But I also have to address the fact that my son gets everything she gets, which is Tricare for life and a lot of other things. So sometimes some people are better off than others, but I do have a daughter that's a physician. So I've worked behind the scenes in the office. I know a lot of things that sometimes you know too much and you get confused. So I question a lot of things. I design my own package. I'm a retired teacher. I actually retired young because I had a lot of benefits that I could come together. I knew I could do it without worrying about staying there until I was 65 or something. So this is the question. This came up just recently. I met with two gentlemen that were pretty much very knowledgeable, somewhat like you, and I told them I had a four-way type package. I had a prescription, I had a supplement, I had a dental, and then I had Medicare. And I could tell them every cost that I was paying. I didn't bring all that with me. But first thing they said was, you know, we could do you one better. I says, really? I said, show me and tell me how. Of course, the material they gave me was very skimpy. It didn't tell me very much. But listen to this. They said that, first of all, I'm not going to mention this insurance because it's a very, very popular insurance. It pays everything. When Medicare kicks in, it covers everything. So I don't have to worry about all this excess baggage, okay? Plus, I can get it when I go out of town because I travel a lot. In fact, I'm going to New York in a few more weeks. So I hope I don't get the snow. But anyway, my premium to them was high, and that they said they could do me one better, and my monthly payments wouldn't be as costly. I said, I'm not jumping on this, because first of all, I have to question the fact, how much would your insurance cover? Suppose I got a catastrophic illness or something, would it cover everything? They couldn't tell me all that, so I said, give me some paperwork. I'll read it, I'll get my investigators, which I know a lot of doctors, plus I'll get my daughter, because she guaranteed me from working with patients that this particular insurance covered everything, and she suggested this insurance I got, so I've had it for several years. So my question is, what do you think about people like me who people tell you're over-insured?
Well, you're not over-insured.
I don't think I am.
You're properly insured. I don't fully understand what they were selling you. If it's anything other than an Advantage plan, a Medicare Advantage plan.
No, it wasn't that. And the other thing.
If it wasn't that, then there's absolutely nothing you should take.
And
You have Medicare as your insurance.
Yes,
Then if it wasn't an Advantage plan and it's not a Medicare program, absolutely run away from
It
that.
was an insurance I had never really heard of.
Well,
And I won't mention it, I'll tell it to you secretly.
Okay.
I don't want anyone to come after me, okay?
One of
But
their selling points seemed to be that you could travel to New York with Medicare, you can travel any place you want in
in the
these 50
country.
states. So
Right.
you don't have to worry about
And your
that.
supplemental plan, your Medigap policy, allows you to travel outside the United States.
Right, not only that, I can get an insurance that when I go travel,
If you go on a cruise, you know, or once you leave the United States, and that's 2 miles offshore on a cruise, your Medicare insurance will no longer work.
it won't.
It will not. So what will work is your Medigap, your secondary policy. So if you are traveling to Europe, if you're going, like I said, on a cruise to the Bahamas, and you get sick, traditional Medicare doesn't cover you. But that's why you have the additional coverage through the Medigap policy. Now, an Advantage plan that we talked about in the first hour, that's where private insurance companies administer Medicare benefits. Those are legitimate health insurance plans. They're safe, they cover the same, by law, they are required to cover the same benefits that traditional Medicare beneficiaries receive. The only difference, why is it cheaper, is because you are restricted to the network of doctors and hospitals that they take. But for someone who's Medicare eligible in the Medicare program, do not sign up for whatever they were selling you.
Oh, I wasn't about to sign up. In
Was
fact,
it a
they were kind of
was it a
disappointed.
faith-based plan? Do you know if it was a faith-based religious organization plan?
No, it's actually an insurance that's been in operation. I did read a little bit of information since 1947.
We'll talk to you off
Yeah.
camera and then
Okay.
we'll ask.
But there are Medicare Advantage plans, and plenty of them out there, that are actually less money per month than what you have today. But as Andrew mentioned, the biggest drawback is that you have to stay in that plan's network. And with what you have today, you have full access to anybody that takes Medicare, and almost every physician and hospital in this country takes Medicare.
The other thing, I said, well, how can I jump into another supplement? I'm out of the enrollment term. I mean, the enrollment.
You're done. You can't
Right,
switch.
you can't switch.
You cannot switch.
There
So
are
I
very-
don't know what they were selling
They
you. They
said I
were.
could switch.
Then he
And I
wasn't
said,
selling you a
this is out of
supplemental plan. It doesn't
context
sound
what I've been reading, that I'm in, after you don't do changes during the enrollment period, you can't change to something else, right?
You can't switch supplemental plans once you sign up. So I don't know what they were selling you, but I don't like, based on what you're describing, I don't think any of us would ever recommend that.
The last question I was going to ask is, do you like what you have now?
Oh, I love what I
And
have.
can
It
you-
might be a little expensive, but I love what I have.
And I understand it's expensive, but can you afford it? You
Yes,
can get,
I can.
Then don't change.
So why would
You have the
wanna
best
change?
coverage.
Why
you
change?
can
And there you
have.
have it.
Don't change it.
Right.
Don't fix what isn't broken, right?
That's
There you
exactly
go.
right.
Very smart lady and a very brave one for taking to the podium and sharing all of that information with us. And if you have a little time after the show, I'm sure they'd be happy to entertain your more specific needs and questions. So for now, thank you so much.
You're quite welcome. Thank you.
All right. We have a question from one of our studio audience members who did not want to be on camera, but they did want to ask their question. So here it is. I will retire in a few months. I have Medicare Part A. I did not get Part B because I had a health plan under my employer. What type of coverage should I pick up after I retire that will allow me to see any doctor I want or specialist, even if outside the state that I live in?
So it's really a nice piggyback to the question we were just answering right in the studio. So the safest way to usually go is just with Medicare, right? And once your employer coverage ends, you have a window, a special enrollment window, where you can then opt back into Medicare, right? So your employer coverage ends, you can get back into Medicare. Now, of course, you can do the Advantage plan as we were all just talking about. It more than likely will be a little bit cheaper, but you will not be able to see every doctor or specialist that you want to. So if you pick a United plan or a Blue Cross plan, you're only going to get to see doctors that accept United or that Blue Cross plan. Where again, if you take Medicare Part B, you'll be able to see basically any doctor that you could, right? Because every doctor really participates in the Medicare program in hospital, very few exceptions.
And just remember, when you take traditional Medicare, for the average American, and there's a table that you can find on the Medicare website, that you pay a premium, a fixed premium for Part B, and Part B, for those who don't know what that is, that's physician healthcare coverage. So Part A is the hospitalization insurance, Part B is the physician health insurance, Part D is prescription drugs. So you'll pay Part A, you don't pay a premium for that insurance. That insurance is paid for by you and your employer when you're working through payroll tax deductions. So you don't actually write a check every month to Medicare Part A. Part B, physician services, comes out of your Social Security check, or you mail in a check depending on how it's set up. And that premium for most Americans is about $140 a month next year. It's a little less than that. If your income is over certain thresholds, the premium goes up, and it can be up to $400 a month. But for most people, it's about $140 a month. And then your Part D prescription drug benefits range in price depending on the plan you get. So you just have to remember that you're paying more money than to have the freedom to go wherever you want to go and see any doctor you want to see. You're going to pay more to have that luxury than if you sign up for an Advantage plan. It's a trade-off. An Advantage plan is a more cost-effective way to go if your resources are limited, but you have to be willing to stay in that physician network. You know, my parents, I'll see them tomorrow. My mom's 75, my dad's 80. Half their friends are on Advantage plans, and they love them. They love saving the money. They love their doctors. They can go to all the hospitals they want to see in Florida where they live. But the other half hate it, and they have traditional Medicare, and they go wherever they want to go.
And another thing to consider for a Medicare Advantage plan, because that usually also encompasses the Part D, the prescription drug coverage component, is to also consider the formulary, the pharmacy component. So if you're somebody who takes a lot of drugs and you're on regular prescription medication, when you're looking at the Medicare Advantage plan, also take a look at their formulary. See if the drugs that you take are on their formulary, so you can have an understanding of what is going to be your out-of-pocket cost for the copays. What are you going to pay for the drugs that you take on a regular basis for that? So it's not just the copays when you go to the doctor's office, it's also going to be what's going to be your out-of-pocket expense for your prescription medication as well. So those are all the things that you need to take into consideration when you're pricing out the cost of a Medicare Advantage plan.
Okay, very good. There are so many questions that you all get on your radio program when you're on, and I just wanted to go to at least one, and you know, because they're so good. Let's ask this one. This is from Becky Carruthers, and she says, my daughter goes to a pain clinic for chronic pain due to mesh and endometriosis, multiple surgeries, and that sort of thing. Patients are drug tested regularly. BCBS has always paid the lab bill. This year, BCBS states that the maximum number was exceeded in a 365-day window. A diagnostic laboratory, we won't name who it was, is charging her $2,000 a test. So they're running her, asking her for $4,000. They accepted $5,156 from the BCBS for the test. She doesn't have any kind of money. She's unable to work, but does have inheritance income, but is trying to make it last as long as possible. What are her options? The pain clinic has dropped the diagnostic agency from her right now. What can she do? What did you tell her, and what will you tell anyone who may have a similar question?
So this is a common problem, and it's not just in lab testing for someone who's got pain issues. And when you have pain issues and you're on prescription drugs for pain control under many state laws, the pain clinics are required to test your blood to make sure, believe it or not, that the pain medicine is in it. They want to make sure you're not requesting pain medications for purposes of selling it. So you have to go to the lab and be tested all the time before they'll refill prescriptions for pain medications. Many insurance companies don't want to cover the costs of the laboratory once you exceed the number of labs you're allowed to get in any one given year. Another example that is quite common is physical therapy visits. You get, Allison, I think you know this, 30 visits a year?
Yeah, depends
on the plan.
By diagnosis.
But
yeah.
in general,
Yes.
so you may get 30 physical therapy visits for your diagnosis in the year, and you're responding well, but you want to go 40 times, and your physical therapist is telling you that, and the doctor's telling you that, but your insurance company may not approve it.
Right.
So you're stuck with having no coverage. You're essentially in a situation, and that listener, that email basically is saying they need to have the test, or if you need the physical therapy, but the insurance company won't pay for it anymore because you've used up your benefit. So what we try and tell people to do, first of all, you should always know that in advance. So it sounds to me like this person didn't know that they had used up all their benefits. And that speaks to what we said before, know what your benefits are. If you know you only get 6 lab visits a year, then don't have 8. It tells you in your benefits summary how much you get. Pay attention. Read it.
Who reads all the fine print?
Read the fine print.
Got to.
You've got to read the fine print and keep it on your desk every year, the summary pages. But in this case, we would tell this person to call the lab and negotiate. When you are, that example is a very good example of how health insurance works. So a charge, what a laboratory charges for something and what they get paid are dramatically different. So the charge for that laboratory test was $2,000. Blue Cross Blue Shield had a contract with that laboratory to pay them $51.56. That's what BCBS is, Blue Cross Blue Shield. So the lab charge is $2,000. If you have insurance and you have Blue Cross Blue Shield will pay $56, which just goes to show you how much higher the cost of that charge is for that test. So if Blue Cross is willing to accept a contracted payment rate of $56, then chances are they'll accept a payment of $56 or maybe of $100 from the patient, not the $2,000. So the key is to call up the insurance company, the laboratory company, and make an offer. Say, I don't have $2,000, so you're not going to get it. You can take me to collection, you can garnish my wages, but you're not going to get anything because there's just no money there.
Right.
Or we know you took $56 from Blue Cross Blue Shield, take $56 from me. 9 times out of 10, they will do that. They will accept that payment. People tend to be afraid to ask that question. Will you do that? Will you negotiate with me? But that's sort of the way to go.
Well, and the other thing you can do too is call the insurance company, who's probably, it's medically necessary that they're getting these tests done, whether it's to check that they're using it or to check their liver function, and say, I need to get these tests. Can you extend the limit from 10 to 20?
Right.
And you need your physician to help you out with that. And the physician will call the medical director at an insurance company, and they can approve additional, whether it's physical therapy or lab draws, to potentially cover it again. And then if that doesn't work, then I would go to the negotiation route.
And it's a good point. I think, and the overarching point of all this is this person needs to take control of the situation. You can't ignore the bill, and if you need your physician's help, you need to call the office. And the last thing the physicians want to do when they're busy is have to call the medical director of an insurance company for their patients, but they will if you stay on top of it and manage your health care.
Okay. Anything else on that? Okay, what I want to do now is I want to remind our viewers that this is The Aware Show, and we are in the middle of a healthcare forum, and we have a wonderful panel here this evening with us from Doctor Radio and the Health Connect program there. We have Andrew, Matt, and of course Allison joining us, who are air personalities and also employees of NYU Langone Medical Center, bringing their expertise to us in Florida all the way from New York. And it's a wonderful thing to have here on The Aware Show that we can address some of the questions that our live studio audience has about their individual health issues and the programs that impact them with their health care. And I appreciate them for sharing their questions and being here with us, and I also appreciate you for being there. We want to go to the podium now with a question from one of our studio audience members. Please give us your name and your question.
Burnett King, and I'd like to thank you, Dee Dee, and WSR for this forum. And just so happened, Allison hit on something about the formulary chart. And I was just wondering to the panel, who devised the donut hole? And look like whatever that mark is in the donut hole, the formulary chart changes, and that's, the insurance company seems to be the ones that sets the price of the drug. So whatever that hole is, I know when I first started out, I didn't reach the donut hole until probably around October. And now I'm finding that it's coming up in July just because of just the way the chart or the formulary chart is set. So how do they Who devises
So that's
that?
it's a two-part question, I told Dee Dee earlier, she asked the greatest question, the first segment. You asked the hardest question in the second segment. The hardest question because the donut hole is probably the single most confusing component of the Medicare program. And Matt's gonna take you through what the donut hole is and the dollars in a second, but it's an excellent question because for several reasons. One, the reason the donut hole exists, and for everybody to know what the donut hole is in general, it's Medicare under President Bush created a prescription drug program. And prescription drugs, as I think everybody knows, are very expensive and the costs are going up every year. So as a mechanism to contain the costs of the program, they put in this hole. And what the hole means, it's when it is basically the time in your benefits when you exceed a certain amount of coverage, you as the individual become responsible for the costs of the drugs. And once you spend a certain amount of money, then you come out of the donut hole and the prescription drug plan kicks in again. And Matt's going to take you through the dollars of that. But that whole donut hole, the whole concept behind it was devised to save money on the prescription drug program. That's all it is. It's confusing. And the way it does that is it says, we'll give you prescription drug coverage, but if you spend too much, you're responsible for that. We, the government, won't pay for that because that's who's funding this. But then if you spend way, way too much because you're really sick, then we'll step in again. And that's the whole concept behind the donut hole.
Yes, what you're actually also experiencing is the donut hole over time. Two things have happened to the donut hole. It's actually taken you longer to get into it. It should by a dollar calculation. So in 2017 compared to 18, to get into it, you have to actually spend $50 more, right? Just over $3,700. But what's happened is the actual cost of drugs have continued to increase. So it may have taken you, let's say, 3 or 4 prescriptions to get into the donut hole yesterday, and you would think, oh, well, now it's $50 longer for me to get in. But your drug costs have gone up more than that. So you have gotten into the donut hole quicker. You should also then get out of the donut hole quicker, right? So to Andrew's point, you have coverage, you go in, you have no coverage. After you hit another spending limit, you come back out, and then you have basically full coverage. And what's happening is the insurance companies and the drug companies constantly negotiate the rates and the pricing and what's on the formulary and what's off the formulary. And it's almost like a moving target, right? You can't get comfortable what it was last year is going to be what it is this year, right? Your prescription was X and it cost you Y in 2017. You still may be on prescription X. It may not cost you Y anymore. It may cost Y plus 5, Y plus 10. So you're right, you're experiencing what all of America is experiencing. The donut hole is actually supposed to close over time. I think it's by 2020.
Yep.
The donut hole will actually go away. There are some implications with healthcare reform.
If the Affordable Care Act stays in place the way it is.
Healthcare reform under Obama had a schedule that goes through 2020 that shrinks the donut hole every year and the costs associated with it. As of now, it's still in place. If healthcare reform went away, and we used to ask this question all the time, because healthcare reform didn't impact Medicare, except it impacted the Medicare prescription drug program. So, and a lot of people didn't understand that. It actually closed the donut hole, meaning you would never have to pay out of pocket. Your insurance would always stay in effect, and you wouldn't have any out-of-pocket costs beyond whatever your co-insurance and co-pays were. That's still in place, but if Congress had their way and repealed healthcare reform, that donut hole would have stayed open, and you wouldn't have had.
Right. That's something that we used to talk about over the summer when they had all the votes I think it was over the summer, to repeal Obamacare, and everyone said this is never going to affect Medicare, but they never mentioned this part of the news. You never heard about it in the media. You never
We're
heard.
not even sure anyone in Congress understood that.
They never talked about it on the news. This is the one piece
actually.
you never heard about it on the news. That this would when they had all the votes to repeal Obamacare, this was a huge piece of legislation that would affect everyone on Medicare.
So any 65-year-old in any state.
Did anyone hear about that in the news? Nobody. This would affect everybody on Medicare Part D, and it was never discussed when they were voting to repeal Obamacare over the summer.
But am I delusional about this? But the insurance company,
They set the price.
Right.
They
That's what
negotiate
I'm
with the
saying.
pharmaceutical manufacturers.
They set the price.
They set the price.
Yeah.
I mean,
So
already know.
United Healthcare negotiates with AstraZeneca, or they'll negotiate with Pfizer for their drugs individually. They negotiate with each manufacturer and how they place each drug on their formulary. And they can negotiate every quarter. The drugs can change quarterly. It could change annually. And that's why your out-of-pocket is going to change. And it's a really, like Matt said, it's a moving target. So
And
you
every
could,
year they update the formulary, so something that was covered in 2017 may not be on the 2018 formulary. They may have switched to a different, less expensive drug.
right.
All right,
Okay.
thank you.
Thank you for asking
good
your
question.
question. Yeah, it's a very good question. It's Andrew said a difficult one, but you all navigated that very well. And speaking of navigating, just in general, help our audience there and here kind of navigate how they would get resource information. I know we can probably go Google and that sort of thing, but how can we kind of navigate how we find the best plan and the information that we need
So
to
there are
make
two
the best
websites that
choices?
people should pay attention to. One, and people tend to not think of the government as being efficient in how it operates, but the Medicare website is an outstanding website. In fact, when, we're not doing it, although Matt actually pulled up his computer just now to make sure we had the numbers for the donut hole, but when we're on the radio, we have computers in front of us, and whomever's not answering the question is actually doing research on the computer to make sure we're giving the right answers, because as we said earlier, there are, every person's scenario of their experience or what's happening to them in the healthcare system is unique. And even though we like to think of ourselves as knowledgeable on healthcare, we can't answer every question. So we have to use the computer too to answer questions. Now we're quick in being able to find the information, but sometimes it's not there. In general, the Medicare website is medicare.gov, and it will answer any senior's question in any scenario, what the rules are, what's covered, what's not covered. So we always direct people to the Medicare website. If you're not on Medicare, there's essentially one or two places to go. You can either go to healthcare.gov. They will answer questions about Obamacare. The problem with that website is you have to know the question. You have to be able to ask the question in the right way, because if you ask a question, it doesn't work like Google does, it won't answer your question. You have to have a specific question that they know how to answer, and they will answer it. And then if that doesn't work for you, then the insurance company's website. So people always say, well, does my insurance company cover this? And they call up, and Allison, they'll ask us on the radio, and Allison goes right to that insurance plan's website, and she'll type in, can you have laser treatment for X? Or if you have the BRCA gene, this came up this week, which is a gene that you can test for that says if you're susceptible to breast cancer or ovarian cancer. Is reconstructive surgery covered if you have the BRCA gene? And in fact, Medicare doesn't cover that. Some private insurances do. But if you ask that question, you can go on the insurance company's website in the search box on the top and say, BRCA gene and reconstructive surgery, and it will then pull up the guidelines, and it will tell you the rules for whether or not your policy, your plan, that company covers that procedure. So there is a lot of good information out there. You just have to be willing to ask it and not be afraid to ask it. So some people are afraid, and I understand why.
People don't want to be on the radar.
They don't want to step up to the
yeah.
podium and ask a question. They don't want to call the radio show because they don't want it. They get nervous, and I understand all that. We don't get nervous.
Don't want my name out there. Don't want you to know.
We don't want to upset the insurance company. Sure. We don't want anyone to find out. But don't be afraid to ask your question. That's the answer. And there are resources.
You won't get the answer if you don't ask the question, right?
That's exactly right.
And you guys are, wonderful. When I think about, you're saying one is looking up and you're getting the information. You're quick also to get the information, but you're also at an advantage because you understand off the top what you're looking at, right?
And where to go to find it.
Yeah, right. Absolutely. And to that end, I just want to say this too. That I do appreciate the people who are coming up to the podium and asking their questions, and all of the people who call your radio station, because they are being brave. And so I just want to say hats off to them for doing that. That isn't always easy. Want to give you guys an opportunity to tell us a little bit about some comments or some things that you would like for people to know, because I don't want the show to end without you giving an opportunity to just kind of share something with our viewers and the audience here about something we may not have discussed yet, but we want to make sure that it's covered before the Aware show's in.
I'm glad you asked that. There's a couple of important concepts and topics to remember. One, I want to remind people that there's a trend. It's new. Several states have passed legislation, and it's in New York State and California. It's called the surprise billing law. So, this comes up. I would say I'm sure everybody in the audience and at home knows somebody whom this has happened to, where you go in to have a procedure. You check to make sure the doctor was in network that was doing the procedure. You check to make sure the hospital was in network that was doing where you were having the procedure done at. And then you get home and you find out that you have a $4,000 bill from the anesthesiologist, you have a $2,000 bill from the pathologist, and you may have a $3,000 bill from the x-ray department, because while the doctor in the hospital took your insurance, the other groups didn't. Now, in New York, you're not allowed to do that anymore. In California, you're not allowed to do that anymore unless you disclose it and patients sign and it's explained to them. And if you don't get all that documented, that you explain to the patient that they're out of network, then the doctor or the organization's not allowed to bill you. And it's a little more complicated than that, but they get the rate that gets paid is different. So check and make sure, if you don't live in a state that has that protection, you want to check and make sure that when you go into a doctor's office or you're going to have your colonoscopy, that which is a common example of where this happens, that everything is covered. And you want to make sure, you can't just say, is my doctor who's doing the procedure covering this procedure? You have to actually know to ask, is there anyone who's going to be involved in my health care who is not in the network of this insurance? You have to actually ask that question and make sure that they answer that question.
Okay, very good.
I mean, one thing for me that stands out is everything in health insurance has a time frame, and you have to know those time frames, right? So whether it's when open enrollment is, when Medicare open enrollment is, when COBRA is, when your COBRA election period is, everything has a defined time frame, and if you don't do something in that time frame, there are no redos, right? So we had a bunch of emails and callers as recently as this week that they said, well, the window was X and I didn't do anything. Well, what can I do now? And unfortunately, our response was nothing. You can't get insurance this year. You're out of luck. Hope you don't get sick, right? So everything has a time frame. So you need to be aware of those time frames and understand them and make sure you take the action in the appropriate time frames, because otherwise, like I said, there are no redos.
Thank you so much, Matt. Allison?
And I would remind our viewers and our listeners to be aware of, there's a term that's been gaining popularity over the last several years in healthcare called narrow networks. So a narrow network plan is something where you can go out and look for a plan that's sold on the exchange or get through your health insurance broker, where they say, oh yeah, we're going to offer you a Blue Cross Blue Shield plan or an Aetna plan. But that plan may have a narrow network plan where it's a subset of the Aetna network that they're selling you, or the Humana network that's in your area. So what that is, it's where they're carving out specific doctors or specific hospitals in your area. So in a way to keep the cost down, to have a lower cost premium plan in the area, that they're shrinking the network, literally shrinking the network to specific doctors, specific hospitals in a marketplace. So they're literally narrowing the network to specific providers. So when you're buying a plan, be aware, if it's called a narrow network plan, just be aware of what you're getting. So again, buyer beware, know what you're purchasing, ask your doctor, do you take this plan, and know that all these plans that they sell out there, they have specific names of the networks. Know the name of the network and do your research. Go online, call the doctor the doctors that you see, call the hospitals in your community and say, do you take this network, this plan?
And this happens every day.
All
I got
the
a
time.
call literally yesterday from an ophthalmologist in New York who's a friend of mine. His daughter had an emergency appendectomy at NYU Langone Health, our hospital, and he said he had Oxford insurance, and I went into our electronic system to see what was going on, and they have something called Oxford Metro, which is a plan that Allison is describing. We don't take Oxford Metro at NYU. So he went to our hospital because he thought he had Oxford, which in New York is a big insurance company. But he didn't read that extra step that says it's Oxford Metro. So he's getting billed now from NYU, and he's out of pocket for thousands and thousands of dollars because he thought he was going to a hospital that accepted insurance. This is a doctor. This is a doctor who works for NYU as a voluntary physician. So pay attention. There's one other thing, Dee Dee. We still have time, right?
Oh, yeah, absolutely.
This has come up a great deal, and I think it would be very important, particularly in the area we're in now where this show is being broadcast. And these are faith-based plans. So you will hear a lot about Christian ministries, religious-based organizations selling what they are marketing as health insurance. And we want to make sure people understand what it is they're getting, because they're actually getting something that's quite different from health insurance. Faith-based plans are essentially group sharing plans where people are paying money into a pool of money and the funds are being dispersed for healthcare purposes for the members of that religious-based organization. And the premiums are much, much lower than what you would find on an insurance company, on the health exchanges. And I think I don't know much about the ownership structure of all these companies. I think that they mean well in what they're doing. We'll accept that. And a lot of people are calling us on the radio saying, I can't really afford a $4,000 deductible. I can't afford a $600 premium after my subsidy with that $4,000 deductible. So, but I see a health ministry plan on the website, and it's $200 a month or $300 a month, and it's only got a $500 deductible. Shouldn't I just sign up for that? And it works like a health insurance plan. If you go on their website, it says we'll cover this, we'll cover that. This is what your out-of-pocket would be, and it's much less money. The problem is, if you actually read the front page fine print of the website, it says at the bottom, this is not health insurance. And this is not a guarantee of payment. So if there's the proverbial run on the bank, meaning their members, a whole bunch of their members get sick, they may not have enough funds to cover all the expenses, or they may limit payment based on certain diagnoses. So if you have a certain type of cancer, they may only be able to cover a certain amount of money towards that cancer. So what we always tell people who come to us with that question, if the choice is between having no health insurance or a faith-based insurance plan, absolutely take the faith-based insurance plan. But if you can find any way at all possible to find the money to have a real health insurance plan with all the protections on pre-existing conditions, with all the coverage available that doesn't cap out once you hit a certain dollar amount, that doesn't exclude any what you'd expect to be covered service, go in that direction. We get that question every week now because health insurance premiums are limited, plans are limited in many parts of the country, and they're expensive in many parts of the country. So this niche of faith-based plans is starting to fill that need with marketing, and it's effective, and it makes sense to a lot of people. I can't afford this. Maybe it's not health insurance, but it's better than nothing, right? But you got to be very careful with these plans because it's not health insurance. And if you find yourself sick, you may end up not having any insurance at all.
And and it's easy for people to trust in their minds a faith-based plan.
Sure.
Go there if you're a person who
and they mean well.
Pretty much,
Allison feels like one, right? I mean, if you go on, it's going to show, as Andrew said, you get this coverage for this coverage for that, but there is a little asterisk at the bottom, right? So when you go on, it feels right. And when there was the individual mandate, these plans were covered under the individual mandate. So if you had one of these, you didn't have to pay the penalty. Now there is no individual mandate. It will be interesting to see what happens with these plans, because I do think a lot of people were going towards them to avoid the penalty. But again, then the alternative for a lot of these patients will be no insurance. And that makes, I think, the three of us pretty worried.
Okay. Well, the thing is that we know the American Health Care Act of 2017, the deadline was December 15th. And so you would think people would say, well, we're past the deadline, what can I do? Can't get insurance. That's pretty much what you're saying at this point. So they're going to have to wait for the enrollment period again. It's closed.
Yep.
So the
Unless
information
you have a qualifying event.
Yeah. There are certain events, marriage, loss of other insurance, if you move, where you can open it up. But if you just missed it because you were lazy, the game's over.
So you need to check and see what those qualifying events would have been to see if you're able to get in.
And remember what we said,
Otherwise,
this
no.
administration shortened the window. It used to be 3 months. You know, when it first started in the first year, it was 6 months. This administration changed it from 3 months to 6 weeks this year. So they cut it in half.
Did pre-existing conditions make any changes between
No changes.
Obamacare
There's
and
still,
going
you
forward?
still have those protections.
Okay,
Although
just-
you hear people talking about it more. Right now, you're still protected.
I'm just going to throw some things out there, and you guys kind of go as we just kind of wind down with our last minutes here, because I want to make sure that I address just something here. We're on the campus of Pensacola State College, and we haven't said anything about the students and that sort of thing. So let's just put some information out there. Still 26 is the age limit where students can actually continue to fall under their parents' insurance plan.
That's
Anything
right.
else out there that they need to know?
Anyone under the age of 26, don't just be a student. Anyone under the age of 26 can
And
be under their
if you don't,
parents.
if your parents can't cover you on their plan, because their plans sometimes don't cover children, or if or it's too expensive for the parents to cover the children, health insurance for anyone under the age of 26, actually anyone under the age of 30, is very inexpensive. Why is that? Because the younger population, statistically speaking, don't get sick as often as elderly people do, right? So to find a policy, it may be as inexpensive as $100 or $50 a month for, you're not going to have the best policy in the world, but you're going to have a policy that protects you if something really bad happens.
Well, and when you say best policy, you really just mean from a financial standpoint.
Right.
The coverage is the exact the
Comprehensive.
same.
That's
I
what I'm
just wanna
saying.
make sure
So
that's
if you get sick, and there are people under 30 who randomly get sick. It doesn't happen as often,
Right.
but it does happen. I mean, we work in a hospital. We see it in the, our studio is in the lobby of the hospital. We see young people coming through all the time. They're the unlucky ones. And you never know, Dee Dee, if you're going to be that unlucky one,
Right.
right?
You never
Hopefully
know.
you know. You don't know who it is. It's random. It's
Right,
You
right.
don't get to predict this. It just happens.
Andrew, Matt, or even Allison, just want to zoom in and focus too on the student concept here as we go forward, because some students are out of state and they have insurance policies and plans under 26 that are out of state plans, or they will say that they're living in this state and they have the coverage out of state. Is there going to be an issue where they're not going to be covered if that's going on?
Okay, this is your second excellent question. So remember, if you are ever in an emergency situation and you are out of your insurance plan's network, you're in college or somewhere, or you're traveling in the United States and you are having an emergency, you will have coverage if you go to the emergency room.
Okay.
You will have coverage. So, but where you get into trouble with students from being out of state is if you wake up in the morning and you have a sore throat, and you think you might have strep throat, and your insurance is from out of state, and you don't have a doctor network in the out of state, and you don't go to the emergency room because it's not an emergency. You may think it's an emergency because your throat hurts, but that's not an emergency to the insurance company. And you walk into an urgent care, you make an appointment with a doctor, you don't have coverage. You're going to have to pay out of pocket. So, this happens a lot. Our parents will call our show. My child is going to school in Oregon. We live in California. What happens, to them if they get sick? Well, we tell them if it's an emergency, if their appendix bursts, or if it's, something bad happens, they'll have coverage. If they want to go see a doctor, it really depends on whether or not your insurance plan has a network of doctors in Oregon, and you just have to check.
A lot of universities and colleges obviously have student health centers that can be free and accessible, so that's something else to check out before you make that appointment with the doctor that may cost you $300. Can I get some free services in the college?
Or you just might have to drive 2 hours if you live
You're near.
in Tallahassee, or you're coming from New Orleans or Birmingham or Mobile, and you go to Pensacola State. You need to, you might have to drive home. If it's an emergency, you go to the emergency room up the street. If you have a sore throat, you'll just have to go see mom and dad and go to the doctor in your hometown.
Okay, hope this is a quick answer because we only have just a few minutes left. What's the difference, our producer's asking this, the difference between universal and single payer?
So, good question. Universal health insurance is I believe, if I'm understanding the question, is a single payer system, right? I mean, single payer system is Medicare for people over
Medicare
65, Medicare for all. So basically, A single payer system is, look up universal just in case we don't,
Yes,
just in
that's
case
the
we know what it
definition
is.
of it,
But a single payer system is everybody pays taxes, higher
Right.
taxes. They pay into a fund to fund health insurance, and everybody, regardless of your age, would get a health insurance plan like Medicare for every man, woman, and child in this country. It's similar to universal, single-payer system is what they have in many European countries. However, understand that even in countries where they have single-payer systems, there still are private insurance markets that sit on top of that. So there actually really is no single-payer system anywhere, because even in places that have it, there's still a segment of the population that still wants private health insurance and actually accesses it.
Yeah, so universal health care really is that it's giving everyone access to care.
Okay.
It may be through a single payer, it may be
Right.
through multiple.
Okay,
payers. That's it.
sorry, Allison, one last question. I want to jump in here and make sure we get in here. Taxes coming up. People got to file taxes and all that other good stuff. Lastly, what can we expect to see? I think you may have answered in the first hour, Andrew, to some degree.
The
What will
individual
happen?
mandate was in place last year. So if you didn't have health insurance, you are going to pay the penalty when you file your tax return this year if you didn't get health insurance. You can still deduct your medical expenses if you itemize your tax returns in 2018. That doesn't change. But tax season for this year, you would pay the penalty. The other thing that you need to know about filing taxes that is, if you overestimated or underestimated your subsidy. So when you get a subsidy, you're basing your subsidy on the insurance exchanges, the part of the insurance that is paid for by the government. That's based on an assumption of what your income is going to be the next year. So if you assumed your income was going to be lower than it actually ended up being, and it was higher, you may have gotten a subsidy that you were not entitled to get. All that is reconciled in either direction on your tax return. If you overpaid because you made less money than you expected and you got less of a subsidy, you'll get a tax refund. If you underpaid, you owe the government the money for the subsidy. There's a form to do that. Talk to your accountant or go online. It's complicated.
It's all complicated.
It is complicated.
I appreciate y'all being here to kind of help us with the maze of all of this. Okay, just one quick closing comment from each of you. Less than a minute. Go, Andrew.
Closing comment is people always say, what can I do? Very divisive time in our country, very polarized society. If you believe in healthcare reform or you don't believe in healthcare reform, whichever way you fall on this argument, your voice does matter. So pay attention to the issue. If you believe strongly that, as we do, that regardless of the flaws of healthcare reform, you need to invest in the system. And you have an opportunity to call your congressman, call your senator, and get it done.
Love it. All right, that's all the time we have for now. I want to thank our special guest here on our panel for joining us here on the Aware Healthcare Forum panel tonight. Again, from NYU Langone Medical Center and host of HealthCare Connect that airs on Sirius XM's Doctor Radio program. Andrew Rubin, Allison Vogel, and Matthew Penziner, thank you all for being here with us. As always, thank you for being there. Thank you all for being in our audience. We're so glad to have had you here. Hopefully, you understand a little bit more about why affordable health care matters for all of us. Until the next time, stay informed and stay aware. I'm Dee Dee Sharp. Good night.